So much of this has been covered, so I will focus on things that haven't been covered. Now, what Lisa wanted to talk about in this talk were when you follow up someone with aortic surgery, there are several aspects that we as cardiologists consider, and what most of this talk is going to be about is about echocardiographic follow-up and probably the dirty little secrets that echocardiographers won't tell you, like that you can't really follow ascending aortas with BAV unless you do CTs as well. So I'm going to concentrate mainly on the echocardiographic follow-up. But I will spend a few minutes talking about some things that have been touched on a little bit this morning, but not very much, about exercise capacity and the prognostic importance of things in the perioperative period like new onset atrial fibrillation, and the prognostic importance of some preoperative things like LV ejection fraction. Obviously it stands to reason if you get AF you're going to do worse than if you don't get AF, and if you've got a bad LV you're going to do worse than if you've got a good LV. But it's the degree of abnormality, the minor degrees of abnormality that have major impacts on postoperative outcomes. For example, you'll see that if your LVF is between 50 and 59% compared to over 60%, your perioperative mortality is double and your mortality during follow-up is double. And we think of an LVF of 55% in someone with AR as pretty good. And it is pretty good, it's just not as good as over 60. So I'm going to touch on some of those things other than echocardiography. Peter and Manu have already referred to the absolute plethora of valves that there are. But the implication of that, on a slide I'll show you later on, is that when you do echoes on patients after follow-up, or even listen to their chest, which is very important in follow-up because of the noise of the click, it drives the patients mad, but as a cardiologist you love hearing nice loud clicks because it means there's no panis. But in it, you've got to know what type of valve it is, because the gradients and the characteristics of the valves you see depend exquisitely on what the type of valve was. So if you do an echo and you see a peak gradient of 55 millimetres mercury, but it's a woman who's small who's had a ball and cage valve, you don't worry. If it's a man who's big who's had a single disc valve and it's a gradient of 55, it's far too small for them, and they've probably got something going on with the valve that needs attention. So knowing the type of valve, and you almost want people to carry a little passport with them, and maybe we should. But knowing the type of valve, as you'll see, is terribly important in the echocardiographic follow-up. Peter's already rehearsed for you the outcomes, both overall and comparing mechanical with bioprosthesis, and this is one of the papers he didn't show. It's 50 to 69-year-old people, 1,000 people who were propensity matched, which is always a bit dangerous, but is actually good when you get up to 1,000, and you can see that the curves are superimposable for 50 to 69-year-olds. Peter made the clever distinction, and I'm sure he's right, that 50 to 59 is very different from 60 to 69. But if you lump them all together, as these authors did, you can see that, as Peter said, the problem with bioprosthesis is you have more reoperation, and the problem with mechanical is you have more bleeding. Now, these data that have 15-year follow-up are by definition 15 years old, and I think that it's very important that in the last 15 years things have changed. The bioprostheses are a bit better and they're a bit larger. The mechanical valves are much easier to manage because of home anticoagulation, which has made a huge difference to bleeding risks. And when you put to a patient, would you rather have a reoperation or a big bleed, they'll always say, I'd rather have a reoperation, so they'll go for bioprostheses. But we desperately need the data about the risk of big bleeds in people who have a Coagucheck device at home. Medicare doesn't cover it, it's $600, but it's really worth it. Okay, now on to echocardiographic examination of prosthetic valves. And there are a couple of take-home messages which I'll show you on the next slide. But here you can see that this is one of the areas with the aortic valve where transthoracic echo is much superior to transesophageal echo, except if you're worried about aortic root abscess and endocarditis, because the angle at which the ultrasound hits the valve is much friendlier in transthoracic echo. You can see in the top diagram that fortunately, in a parasternal long axis view, the sound wave comes absolutely perpendicular to the valve, so you can see open and closing very well. And if you come from the apex and tilt up a little bit anteriorly, the sound wave is almost exactly parallel to the valve. So you get anatomical information beautifully from the parasternal view, and you get functional information beautifully from the apical view in someone with good windows. So with TOE, you can see here, you often get quite bad shadowing in just the areas that you're most interested in. So that's not to denigrate TOE, but it is to say, as opposed to the mitral valve, you can get really excellent information from transthoracic echo from the aortic valve. Now this slide has everything you need to know, and I'm going to spend the next 20 minutes explaining it, but just please remember this one. So they should have a transthoracic echo before they go home, and you'll see here measuring LVOT D diameter. That is kind of really critical. It's hardly ever done, but just got to measure the LVOT D diameter, and you'll see why that is in a minute. 12 months after surgery, and then all the recommendations are 3 years every time thereafter unless there's a problem. Now, when you see a table where normal possible stenosis and significant stenosis and you need to measure 6 parameters, it's usually because no one parameter is good enough. And so I'm going to share with you some of our dirty secrets why one parameter is not good enough. But you can see that peak velocity gives you some guideline. But of course that depends on whether there's any MR or AR, how big the ventricle is, how vigorous the cardiac contractility is. So it's a kind of a pointer, but it's not fantastic. The mean gradient, because it's derived exclusively from the velocity on echocardiography, is even worse because you take the square of the velocity, so any inaccuracy in the velocity is squared. And so these mean gradient data, you pretend that because you're meaning at over 60 data points, it's more accurate than if you take one, which is what your peak velocity is. And that's probably right. But you've got to understand the limitations inherent in saying a mean gradient's better than a peak velocity without knowing that gradient's just derived from the velocity in the first place. DVI is the best of all because it's really simple and it's easy to understand. It stands for Doppler Velocity Index. And as you'll see in a moment, all it is it's the velocity of the continuous wave jet across the aortic valve divided by the velocity across the LV outflow tract. Okay, you do PW on the LV outflow tract and you do a CW across the aortic valve and you divide one by the other and it gives you the answer almost all the time. And that's why a moment ago I said it's very important to know what the left ventricular outflow tract is like pre-operatively, because that's where you get your information from. So the DVI, and you'll see the data on that are really compelling. Now, if you remember only one thing from my talk, please make it this. Every patient has their own DVI, which is available to you when they've recovered from their surgery 30 days post-operatively. So if you've got a 70-year-old woman with a 19mm cage valve, or you've got a 20-year-old man with a 27mm disc valve, you will know what their DVI is when they're well, without thrombus, without pannus, without LV dysfunction. And that's like the patient's passport number or their footprint or their fingerprint. And I tell all my patients, I say, just remember this, your DVI is 0.4. So if you're in Brisbane with Greg, who'll do a much better echo than I did, but if you're in Melbourne with Peter's guys, you just tell them your DVI was 0.4 and then they'll know if things have changed. Okay, it's an easy number to remember and everyone should be know what their DVI is. Okay, now the effective orifice area is really interesting. Look at that. Normal is greater than 1.2. And Peter just told you that normal is actually 3.0. So every time we're putting in a prosthetic aortic valve, mechanical aortic valve, we're giving our patients mild to moderate aortic stenosis. Okay, how ironic is this? You just saw an STS recommendation that if a valve is 1 centimetre squared or less, that is so severe that it's an indication for surgery. But we say after aortic valve replacement, everything over 1.2 is okay. So please remember, when you're putting in a new aortic valve to someone, you're giving them mild to moderate aortic stenosis, and if they're a big person, you're giving them moderate to severe aortic stenosis, and yet we'll still call it normal. What normal means is you're not going to go and re-replace it, but you're really giving them a very substantial functional limitation, and they've got to understand that. If you put that with the intermediate septal motion they get from myocardial protection issues and you give them a valve of 1.2, it's not hard to understand why there's a functional impairment. The contour will come back into a moment and the acceleration time will come back to in a moment, but this grid gives you a mechanism whereby to find out if your patient who's had an aortic valve replacement is functionally going to be limited by the aortic valve replacement or not. Now, the EOA calculation is, Greg's already shown it, and it's easy. It's just, when we say continuity equation, what does that mean? Well, it means that the amount of blood above the valve is always the same as the amount of blood below the valve, because you're not making or taking blood away between those two places. And so the area times the flow there is the same as the area times the flow there. And if you want to know what the area is there, all you need to know is the area there, the flow there, and the flow there, and then you've got it. So the effective orifice area for a replaced valve or a native valve is the cross-sectional area in the LV outflow, the velocity time integral in the LV outflow, and the velocity time integral in the jet through the aortic valve. Now, this is where I have to share with you, and Greg's made it much easier for me. This is our worst kept secret, and that is, firstly, let's give us the benefit of the doubt that the left ventricular outflow really is a circle. Of course, it's nothing like a circle. It's a complex polygon because of the aorticomitral curtain and then the ventricular septum and then the aortic annulus, sort of 120 degrees of the circumference. So it's nothing like a circle, as Greg showed on the CT scans. But pretend it's a circle. Now, when we insunnate an aortic valve as a sonographer, you put on the transducer and you look for two leaflets opening, because that makes you think you're in the middle. Of course, that's absolutely wrong, because when you're right opposite the main opening part of the right coronary cusp, you're right in the commissure between the left and the non. So what you should actually be looking for is an anterior leaflet that's doing that and nothing on the posterior wall. Then you'd be right in the centre. But we just can't do that. We just don't know how. You think, you want to look for two leaflets opening, and we always do. So what error does that introduce? Okay, got a circle, and if you were right in the middle, you would get the true maximum diameter of the LV outflow tract. Now, basically, you don't have to know the trigonometry I'm about to tell you, but if you're 45 degrees off, if you're really off, you'll cut the diameter in half, so you'll underestimate the area by 75%. Okay? Basically, for every degree you're off centre, you're going to underestimate the diameter by 1%. Now, we're normally between 5 and 10 degrees off centre, and Greg showed a beautiful slide. Instead of being right in the centre, when we look for the left or the non posteriorly, we're between 5 and 10 degrees off. If you're between 5 and 10 degrees off for radius, you're between 10 and 25% degrees off for area. Because in this formula, when you work out cross-sectional area is just pi r squared. So if you're underestimating R and it's 0.9 of what it really is, the square is 0.81 of what it really is. So it's not a 10% error, it's a 19% error. If you've made a 19% error in your cross-sectional area, you're going to make a 19% error in your effective orifice area. Now, if I go back up to here, a 19% area is the difference between significant stenosis and possible stenosis. So this is the reason why there are 6 rows in this slide, because nothing we do is particularly good. Okay, it's good when you put the composite of information together. Okay, echocardiography is an amazingly powerful and good tool, but it's important to understand the limitations. And the most important limitation of all is because this magic number of effective orifice area is based on a derived value which is dependent exquisitely on that diameter, where small errors will have big consequences. That's why you should always look at effective orifice area with a little bit of a grain of salt, and if it doesn't make sense with the other things, that's possibly the one that's wrong. Now, this is the kind of table that you've just got to have in your echo lab. Remember earlier I said that for every kind of prosthesis there is a magic number. And you can do it here. You've got, a St Jude medical has been put in, and it's a 23mm valve, and this is what you expect your effective orifice area to be, 1.5. Okay, you look it up on the table so that you're not unduly alarmed by a number that's high. Have a look. Let's pick something. Here's a 19mm St Jude or Carbomedics single disc valve. You expect an EOA of 1. You expect severe stenosis. Okay, that's what you expect. So if there's a gradient of 55 with a good left ventricle, you say, yeah, that's what it is. I'm not worried about that. Okay. So the parameters I've just been talking about, the EOA and the DPI, the Doppler Velocity Index or DVI, are so-called flow independent. They're better than gradients because they're independent of the amount. That means if you've got a good left ventricle or a bad left ventricle, if you've got AR, which has made a big volume that has to cross the valve, or no AR, doesn't matter because it's independent of the amount of flow. So you just need the velocity here and the velocity there, and you divide one by the other, and if you've done that early, you've given your patient their fingerprint. Okay, a couple of tips and tricks. The LV outflow velocity needs to be measured just below the valve. You can see there, this is a TAVI case, but there's a D1 and there's D2. Take D2. It's more accurate. Okay. You can see what a substantial difference it'll make because 21 as to 24 is an error of 15% of diameter, but that's an error of 35% of area. Okay, now, this is a really interesting thing that we maybe don't think about as much as we should. Here, when you're doing an echo and you produce a Doppler profile, you've got these really loud echo noises from the valve closing. And that's, that gives you a sigh of relief because if the valve is closing and making a loud sound, it means it's not getting stuck. This is an obstructed AVR, and although you can see that the gradient is high, here's a peak gradient of 80 and a mean gradient of 45, the other thing you can see is that the prosthetic click noises are dampened. And that's often a very good sign, and I'm sure many of you who do this a lot will have had patients come to you and say, I just noticed a week ago my valve's not as noisy as it used to be. But you can pick that up before your patient can by looking at it there. Okay, so as I mentioned, LV outflow diameter is a source of technical error. Using the pre-implant LVOT measurement, if available, is really useful. I say there, or Lisa says there in her slides, that assumption of a circular orifice can be erroneous, but there's not much you can do about that. Even if you size it with a CT, you're still stuck with an assumption that it's a circle because in echo you only get 2 dimensions at a time. And as I mentioned, you can only really get that in a parasternal long or short axis view because no other view is accurate enough. So just understand that it can give you a limitation. And the AVR prosthesis size versus the LVOT diameter will give you a good insight to the thing that bedevils this field more than anything else, and that's patient prosthetic mismatch, which I'll mention in a moment. So when you're evaluating the gradient, this is just a practical example. This is a 50-year-old man who had a 25mm mosaic, which on the surface of it, you think 25mm for a man, that's a bit small. Effective orifice area that you expect, if you look it up in that table that I just showed you, is 1.7. He had increasing shortness of breath, so you measure that D2 just below the sewing ring. Here's the LVOT VTI. Here's the aortic valve VTI. This is continuous wave, that's the pulsed wave. So if you put that into your formula, you get a DI of 0.26, which is lower than you want. But if you work out his effective orifice area, you really should normalise it for body surface area. And this was a big man, he was 6'3" and weighed over 100 kilos, and so he had a body surface area of 2.5, which gave him an index DOA of 0.65. And that's really low. Now, Manu and Peter both went to great lengths to say that the evidence for pre-operative decision-making for aortas shouldn't really depend on body surface area. And this is a different point altogether. You are allowed to adjust for body surface area when you're talking about aortic valve areas, particularly post-operatively. It's an important thing to do. Okay, now the next thing that changes if you've got an obstructed prosthetic aortic valve is the shape of the signal changes and the so-called acceleration time changes. So here on the left is a valve that's working great with a DVI of 0.4, and here on the right is a valve that's obstructive. And the two things you can notice are in the great valve, they came from the same thing. The acceleration time, which is the time from the valve opening to the peak velocity, is under 100 milliseconds. It's 75 milliseconds. So this is a really easy measurement to make because you've got a very clear point of opening and you've got a very clear point of the peak. And because the acceleration time here is very early on in systole, the shape of that envelope is sort of triangular, okay, because the upslope is much shorter than the downslope. So this is said to be a triangular profile and this is said to be a rounded profile, but it actually all comes from the fact that the acceleration time, and this makes good sense. If you've got a lovely aortic valve that'll fling open and a healthy ventricle, all the blood leaves very early on in systole. So that's why you get a triangular shape with a short acceleration time versus a rounded shape with a long acceleration time. And this is actually a pretty good parameter and, again, not very routinely measured. Now, a couple of words about bioprosthetic valves. Peter showed a couple of lovely photos of degenerated bioprosthetic valves, and you can see that the echo sign of that is increased echogenicity. Lisa here makes the point that if someone's valve annulus is rocking, that's clearly a horrible sign and is almost pathognomonic of endocarditis. Disc motion, if you're worried about one of the discs jamming, you can often appreciate that on echo, but because of the angle of insonation and the way the discs move, you can't ever measure it very accurately, and fluoroscopy tends to be a much better way of doing it, which you can see on this slide. That's a CT on the top, but just taking them to the cath lab for a moment. And every valve has a normal and known angle of opening. So this is obviously a St. Jude bileaflet valve, and you can see that on fluoroscopy, if you just have to fiddle the tower a bit to get it absolutely perpendicular to the valve, and you know that from the valve ring, and then you just measure the angle of opening on fluoroscopy, and that's actually a much more accurate way of getting an idea of whether the valve is getting stuck or not than echocardiography. So echo will give you the stethoscope will give you the clue because the click isn't loud. The echocardiogram will give you the indication that there is something going wrong because the gradient is high, the DVI is low, the EOA is low, and the acceleration time is slowed, and then the fluoroscopy will give you the answer. Okay, so if you've got an increased gradient post-AVR, what's the differential diagnosis? The commonest, well, I guess the single most important thing is it new? Was the DVI 0.28 after the operation and it's 0.28 now, or was the DVI 0.4 at 1 month and it's 0.28 now? And that gives you really important information as to what the etiology is going to be. But the two commonest etiologies of increased gradients are patient prosthetic mismatch and high flow states. High flow states usually being fever, anemia, pregnancy, thyrotoxicosis, aortic regurgitation or mitral regurgitation. This is the one you dread and the one where you have to call the surgeon back up again, which is valvular obstruction from one of those three causes. So just a word or two about patient prosthetic mismatch. The criteria are different from the aortic and the mitral position because obviously the mitral valve is it's a much bigger valve, and B, the flow occurs across diastole, which is much longer than systole. The aortic valve has to empty during systole, which is much shorter. And it just shows you the threshold values of concern for effective orifice area when you index it for body surface area. Now, patient prosthetic mismatch is quite common, obviously, especially with mechanical valves and sewing rings. And you can see on the bottom line there that the prevalence of severe patient prosthetic mismatch is between 2 and 20%, depending on the series and the age of the patient, and moderate in 20 to 70%. And that looks like a very high number, but that shouldn't surprise you in view of my previous comments of what the effective orifice area of a prosthetic valve that's working normally is compared to a valve area of someone who's never had an aortic valve operation. So PPM is terribly common and it's terribly important. This is Lisa's deliberate mistake to make sure that at least I'm still awake. She's indicated PPM as the black line, which would make you think that PPM is good for you. In fact, PPM is the grey line and PPM is bad for you. So patient-prosthetic mismatch, and this is mortality. This is something important, not just an echo lab finding. So this is, if you have a great echo lab, like we're lucky to have in our hospital, you can do all of this. If you are in rooms and you're doing an echo every 5 minutes, you look at the aortic valve jet, and if it's under 3, you're happy. The gradient, if the peak velocity is under 3, go home, you're happy. Or the patient's happy. Then, if the velocity is over 3, you go down this trickle pathway, which is if the DVI is over 0.3 and you've got this nice triangular shape, go home, it's fine. If it's rounded and the acceleration time's wrong, there's probably a mistake, because the DVI is pretty fail-safe. On the other side, if the DVI is low and it's rounded, you're in trouble. Okay, so this is a pretty easy way to go about assessing prosthetic valves. Thrombus is obvious. Pannus should be obvious now. Okay, I'm going to skip over this because paravalve leak has been covered a bit, and really it's not any different to assessing native aortic valve regurgitation. Peter just invited, he tantalisingly said, cardiologists will probably know more about when you replace an aortic valve than my one-line slide. So we do, and we have a one-line rule, which is the 55 rule. If the end systolic diameter is more than 55 or the ejection fraction is less than 55, replace the regurgitant aortic valve. So it's the rule of 55. As opposed to mitral valves, which is the rule of 60. But we're not talking about mitral valves today. Okay. That's a dehisced aortic valve prosthesis because of aortic valve endocarditis. So the summary of recommendations for echocardiographic AVR replacement is on this slide. We look at chamber volumes and ejection fraction. We look at the aortic valve, particularly with these flow-independent indices of DI and EOA. And don't forget the aortic root. And that is what a really good echo lab does. Okay. And they are the frequency of assessment, so 30 days, 1 year, and every 3 years or so. Sorry, bioprostheses you have to follow up much more frequently because of the degeneration issue. Okay, just a couple of words to finish up about some post-operative problems that are unrelated to echocardiography. This just shows that your functional improvement, this is from the partner trial, which was the trial that Peter just spoke about, a TAVR versus surgical AVR in patients who are eligible for both. And it just shows that you get better whichever you have, which makes sense because you're fixing the aortic stenosis. Now, what about MACE rates? It's just to show how important new onset atrial fibrillation is. It occurs, isn't this wide, eh? This isn't very helpful, 15 to 64% or 4 to 32%. It's basically someone or everyone. It's about 20 to 30% in surgical series. And it has very poor prognostic importance, particularly with a poor LV. So here are the AF versus SVR. It depends on whether someone's had a pericardiotomy or not. So this is the percent of patients with a pericardiotomy who get AF if you monitor them closely enough, and that's with no pericardiotomy. And so every unit has its own way of managing post-operative AF, but it's very common. Even if you manage it, unfortunately, it has worse outcomes. A word about the other PPM. I was talking about patient-prosthetic mismatch before, but you know, with 26 letters in the alphabet, 1 in 26 cubed acronyms are going to be exactly the same. So there are 2 PPMs in one talk. This is permanent pacemaker. What's the risk of permanent pacemaker? High. 5,000 procedures. If you've got left bundle branch block, your risk is 13-fold higher. AVR, for the reasons that Greg showed and then Peter rehearsed, because you're very close to the left bundle, there's an 8-fold risk of PPM. And if you have a PPM, you die more often, but it's not as bad as AF. Now, this is the one I said at the beginning. If your LV's bad, that's bad. Go figure. But look at this. This is the 50 to 59%. This is the normal. Then 50 to 59. So anyway, it's bad. Okay. The worse it is, the worse it is. But what's really interesting is it starts to get bad even at 50 to 59%. I'm finishing, Sharon, I promise. Okay. LVF is important. You get better. Okay, I want to say one thing about thoracic aortas because it's all been said already. CT and MRI are far better than echo. Echo misses things, and the most important thing echo misses is aneurysms in the descending thoracic aorta. You just can never see far down enough. And a word about coarctation. If I'd have been giving this talk with my own slides, it would have all been about coarctation because that's fun. We just published the results of 300 coarctation survivors. Before our series, the median age at death was 38, but that was in a long gone era. It's now median age at death is over 60 because half haven't died when they're 60. But about 1/3 have had a re-intervention on their aorta. Ascending aortic aneurysm in about 6% because 85% of coarcts have BAV. So like any other BAV, they can get an ascending aortic aneurysm. But the descending thoracic aorta is the trick. 30% of neonatal coarct repairs get recoarctation. And if someone's had a Dacron patch aortoplasty, about 30% of them will get an aneurysm late. So although they live longer, they get a lot of aortic complications. So a coarct is fixed but not cured, and an echo is not good enough to pick up the problems. Thank you.